Hello, this is Dr. Gary Siskin, and this is the first in a series of lectures regarding embolization procedures. In this lecture, I'm going to focus on general principles of embolization. While embolization procedures cover a lot of different disorders in a lot of different patients, they are essentially similar to one another. We take a patient, we put that patient on our fluoroscopy table in our angiography suite. We usually use a catheter to gain arterial access, although sometimes we gain venous access. And then whether or not we're treating a uterine fibroid, or we're treating a renal angiomyolipoma, for example, or a patient with splenic trauma, what we're trying to do in each of those cases is to place a catheter directly into the abnormal vascular bed and then inject something into that vascular bed which will occlude flow. And the hope is that by occluding blood flow to that particular area, we're going to accomplish our clinical goal. If you're going to take it upon yourself to embolize stuff, there are a number of things you have to understand. You have to understand the pathology that you're treating. You have to understand the clinical implications of using embolization for treatment. And you have to understand the ideal technique for the particular condition that you're treating. That includes both the embolic agent that you're using as well as the delivery catheter that you're using to get that agent where it needs to go. I think most people, if they have appropriate training within an appropriate program, they're going to understand the third part. However, I think that in order to really claim expertise in this particular area, you have to spend a lot of time focusing on the pathology that you're treating and the clinical implications of what you're doing. For all patients with any condition that you're considering embolization for, there's a correct way to utilize this procedure for treatment. The problem is that we don't always know the correct way. There is no doubt that every interventional radiologist is going to do these embolization procedures differently, and they're going to do them the way they think is best. And this is going to have to do with previous teaching, perhaps an interesting article or two that they read, available inventory within the hospital. It's certainly going to depend on how much time they have available to do the procedure, plus a host of other factors. Everybody will do this differently. In these lectures, I'm just going to review my approach to these procedures. But first, let's focus on some history. And I think the first time we can say that something resembling an embolization procedure was done was in 1904. When head and neck lesions were essentially embolized preoperatively through the direct injection of melted paraffin and petroleum jelly essentially into the external carotid arteries to reduce tumor blood flow. Nothing was really done with this until 1960 when Lussenhop and Spence occluded a cerebral AVM by directly injecting silastic beads into the carotid artery. When it comes to percutaneous embolization, the first cases were reported in 1968, and these were actually separate case reports which described the percutaneous embolization of spinal cord AVMs. The first report by Dotman used 3 mm stainless steel pellets for embolization, and the second report by Newton and Adams used lead pellets and small fragments of muscle for embolization. Much of the work in the early 1970s was focused on the use of embolization to treat GI bleeding, and none of this could have happened without the work of Stanley Baum, who provided the preliminary information needed for this to occur. In the early 60s, he reported that cut film angiography could demonstrate contrast extravasation at rates as low as 0.5 cc per second. And in 1967, he helped develop the technique for controlling GI bleeding with intra-arterial vasopressin. It wasn't until 1972 when Joseph Roche published the first case of arterial embolization to treat acute GI bleeding using autologous clot and an epinephrine infusion. At this point in the 1970s, it was really the work of 3 pioneers which helped move embolization forward towards what it is today. The first person was Kurt Amplatz, and he was one of the first to report the successful use of particulate embolization with PVA, otherwise known as Ivalon. And later, Dr. Amplatz developed the embolic plug, known today as the Amplatzer vascular plug. Dr. Gianturco was responsible for developing embolization coils in 1975 as a permanent agent for embolization. And these were made by removing the mandrel from a steel guide wire and then adding wool fibers to increase their thrombogenicity. But what was immediately noticed was that the wool fibers led to an intense chronic granulomatous arteritis. And this led manufacturers to change the fibers to synthetic Dacron in 1979 because this was not associated with the same type of inflammatory reaction. And finally, Bob White is someone whose work I like to read because he was responsible for much of the early research on the characteristics of different embolic agents, and many of his findings still stand today. He then became known for developing techniques for treating pulmonary AVMs and varicoceles. It was the work of these pioneers that laid the foundation for the embolization work that we do today for so many different reasons in so many different patients. And the list is actually far longer than what I've presented here. You can look at trauma, visceral aneurysms, pre-operative work before Y90 administration or endovascular repair of AAAs. You can look at the work we do in pelvic veins to treat varicoceles and pelvic venous disease, GI bleeding, AV fistula maturation, embolization work can be done. Then there's a whole host of other indications such as uterine fibroid embolization, PAE, geniculate embolization, bronchial artery embolization for hemoptysis, preoperative tumor embolizations and embolization to treat angiomyolipomas. Then there's all the work we do in interventional oncology, such as radioembolization and chemoembolization. And then there's other indications like partial splenic embolization and embolization to treat priapism. Obviously, an important part of learning about embolization is understanding the technique and the materials that we use for these procedures. Throughout history, a lot of people have referred to the arterial system as an arterial tree, so why don't we just go with that analogy? And let's look at two different types of pathology that we might treat. The first can be highlighted by this red circle. It doesn't matter what the pathology is, let's just say it's located there. In this particular case, we can take a catheter and move it from the bottom of the tree to the exact site of the problem, and we can then deploy an embolic agent at that exact site. But what if the pathology is all the way out here by this yellow circle? Well, in that particular case, we can move a catheter as close as possible to the site of the problem, but we may not be able to get all the way there. And in that case, we have to rely on flow to deliver the embolic agent to that particular problem. So I like to classify embolic agents as being either mechanical agents or flow-directed agents. For mechanical agents, we position the catheter directly at the site of a vascular abnormality, and then we deploy an embolic agent directly at that site. For flow-directed agents, we position the catheter near the site of the abnormality and then let flow deliver the embolization agent to that site. Now, I do think it's important to be able to classify the different embolic agents available to us. I think it's important for people doing these procedures and important for people learning how to do these procedures. Because I think if you can effectively classify them, it means that you have an understanding about the technical characteristics of the agent and the reasons why we might choose to use a particular agent. Through the years, there's been lots of different ways that people have tried to categorize these agents. I've seen people classify them as large vessel versus small vessel agents, permanent agents versus temporary agents. There's lots of different ways to do this. I like the way I just mentioned, mechanical agents versus flow-directed agents, and this was further clarified by WHO in 2019 when this chart was developed, and I think by color-coding this, you can see that you can divide these agents into the green mechanical agents or the more pink flow-directed agents, which include particulates and liquids and gels. And once you have this classification scheme down, you can then realize that some agents are better for certain indications than others. So if you look at that list I presented earlier, all the indications on the left side would be more effectively treated by mechanical agents, and the ones on the right can be treated with flow-directed agents. Now, obviously, there's some room for improvisation here, and people are using liquids to treat some of the indications on the left, such as traumatic bleeding or GI bleeding, and certainly mechanical agents can be used adjunctively in some of the indications on the right. But I think, generally speaking, people are using one or the other for different sets of indications. So with that in mind, let's look at some general principles about the performance of embolization procedures. All embolization procedures start with an evaluation of the patient. It's necessary and in fact mandatory for a thorough pre-procedure evaluation by an interventional radiologist to take place. And this can occur either in an outpatient office or at the bedside for inpatients. I think interventional radiologists must be the ones who make the final decision as to whether or not a patient is an appropriate candidate for embolization. Once we get past that evaluation, we have to start planning the procedure. First, we're going to think about the embolic agent that we want to use in the setting of a particular clinical indication. So it's important to have a plan for the agent that we're going to use before we start the procedure. And the choice is usually going to be guided by the pathology that we're treating, as well as the anticipated catheter position that we can achieve for the embolization. We also have to think about the delivery catheter. I know for sure that most interventional radiologists don't pay enough attention to catheter selection prior to the point of embolization. Everyone likes to think about the pathology that they're treating, the acuity of the procedure, and the embolic agent selection process. But few people think about the catheter that they need to deploy a particular embolic agent and what's required to get that catheter where it needs to go. So you have to ask some questions. Does the agent that you're planning to use require a microcatheter, a standard angiographic catheter, or a guide catheter or sheath? If you're going to be using a microcatheter, do you need one with a small inner diameter or a large inner diameter? And if you plan on using multiple different embolic agents during a procedure, then does your desired catheter position allow you to change your catheter midway through a procedure? Despite all this planning, it's critical to be flexible during any procedure. For starters, selective catheterization is not always as easy as it looks, so you need to have different catheters and guide wires available to help get you where you need to go. In addition, if you do end up changing your catheter, that may necessitate a change in the embolic agent that you're able to use. For example, if you're planning to use a plug that requires a large delivery catheter, but you can't get the catheter there, you have to be prepared to potentially use coils through a smaller catheter. And if you're planning to only use coils for a procedure, but can't get all the way to the planned site of embolization, be prepared to use something like a liquid, which may help accomplish your clinical goal. So in other words, life is all about how you handle Plan B. And then there's the issue of the endpoint. People are always asking, when do you stop embolizing? My thought is this: I want to do the job once. And I actually dislike it when I hear people say, I'm sure it will thrombose in time, and they use that as an excuse for not embolizing to completion. To me, that's a fail. I believe that you should never compromise your original plan. If your goal was to completely embolize a vessel, then completely embolize the vessel. The idea that you can incompletely embolize a vessel and that thrombosis will occur in time is an unreliable strategy. Yes, it may work sometime, but it won't work all the time. So I encourage people to take the time to definitively embolize the target vessel and don't leave anything to chance. Once the procedure is done, the patient that we treated needs to have some follow-up with us. It is simply inappropriate for a physician providing a therapeutic service to not participate in the post-procedure care of that patient. Nobody understands our procedures and the potential post-procedure issues that they may experience better than we do. And frankly, this is part of the deal. If you want to do these interesting cases, you have to assume responsibility for some or all of the patient's care. Remember, there's rarely any visible manifestation of the procedure that was just performed. Most patients leave an IR suite with nothing more than a Band-Aid. And because of that, most patients assume that the job was done and was done well. I think we can distinguish ourselves as physicians by the post-procedure care that we offer. We have to counsel patients and their families regarding what they can expect as they recover and then beyond the immediate recovery period. And we also have to establish an easy way for patients to reach us in case they have questions. It's also important for all physicians performing embolization procedures to have a quality improvement program in place. We need to collect and evaluate data to determine the appropriateness of the indications that we've used for embolization, the degree of success we're achieving after these procedures, and the incidence of complications. And a good quality improvement program allows us to identify problems and put corrective measures in place. In conclusion, embolization has evolved into the procedure of choice for so many different clinical indications. Expertise with this procedure comes when you appreciate the technical nuances of the procedure and embrace the patient care responsibilities that come with each procedure.